So again, welcome to the panel where it's on AI's promise in personalized medicine through patient treatment matching. I'm really fortunate to have three experts here on very diverse backgrounds in oncology, drug development, and neurological reproductive treatments. I'll start with our first panelist to my right, Ana Garcia Poyo. Ana brings some unique insights from both reproductive and neurological medicine. She's a leader in the first IVF automation company to secure Google Ventures investment in Spain. She pioneered AI applications in fertility treatment, and now she's revolutionized the ADHD diagnostics using EEG-based biomarkers and AI-driven analysis. Her work spans from helping create life to understanding how our brains work, and she's also a fitness expert. Our next panelist is Albert Planas. Albert works at Sanofi. He leads one of Sanofi's data science teams in digital R&D, and where he's breaking new ground in spatial omics and clinical trials with a PhD in AI and 15 years in life science. He's bridging the gap between complex biological data and practical medical treatments. And then we have our panelist at the very end, not last but certainly not least, Christophe Dufour. Christophe is at AstraZeneca, and he has digital precision healthcare at AstraZeneca. He's focusing on oncology and rare diseases. His work is particularly crucial as treatments become more complex. We just had a panel on that. And imagining coordinating treatments that might only apply to 10,000 patients worldwide. He's developing AI systems that can process everything from medical images to genetic data to help match these patients with optimal treatments. So, really fantastic panel, very diverse group. I forgot to mention in my very lengthy intros, Albert was a Westworld extra. And Christophe, I mean, listen, this is the first time I've had an opportunity to introduce a tiger attack survivor. So we'll integrate a little fun into this very deep conversation about AI and personalized medicine. So I'll start with Ana. So speaking of precision and discipline and fitness, as someone who understands both the fitness world and medical precision, from IVF automation to EEG patterns, how is AI personalizing treatments in both spaces, from embryo selection to brain connectivity patterns?
Okay, so I will start with the fertility space. The role of AI is key to democratize IVF. So basically, I think everybody's aware that fertility rates are collapsing. The cost of IVAs, we even speak about baby economics, right? It accounts for 40% of the personal income in some cases. And the success rates are really, really low. So you need like 2 to 3 cycles in average to get a baby, right? So basically, I think the first point really is how you can improve access, improve success rates, and lower the cost of IVF by at least between 30 and 40%. Some of the applications I have been working with, one is embryo selection, and I think in general, in any holistic diagnostic, what is happening, I mean, in the same way you go to the hospital and you get the X-rays and your gene test, a genetic test, or a blood test all consolidated, AI is enabling the same for embryos, right? So you can get a metabolomics AI-powered solution that is linked with computer vision, and that in the end is helping to reduce the number of unsuccessful cycles in IVF. That on one side. On the other side, a complete different story, but where I'm working right now, it's psychiatry. That it's a really complex discipline, right? Because when you have a problem in your heart, everybody's looking at the organ and how to really treat the root cause of what is happening. In psychiatry, nowadays, there is nothing, we don't know exactly what is happening in the brain, so basically AI, it's enabling to move from a behavioral diagnostic process to the biological lens. What are we doing in this sense? We are using AI to define endophenotypes that could be, and we have a diagnostic biomarker for ADHD that I think it's a very complex cognitive disorder that it's applicable to 5% of the pediatric population, and nobody is really knowing what is happening. So I think AI is enabling to understand what is really happening in the brain and to stop diagnosing just looking at symptoms, right? So on one side. And the endophenotype, I think it's also a big area because in the case of the ADHD, the treatment, it's almost the majority is methylphenidate, that it comes from the amphetamines, but nobody has really looked at what is really happening in the brains, which connectivity patterns are affecting and can really improve, right? So this will be for me the two areas where I think, so on one side, I think the improving access and side, and democratizing, and also trying to understand what is happening in psychiatry and move to a more biological lens.
Great. Thank you, Anna. I appreciate it. Just a quick question. How do you think we should balance AI automation with human clinical judgment?
I mean, I think in the same way when you drive a car and now we're going into the driverless car, I think the doctor should be like the co-pilot, right? So when you speak about AI and the future of work, they always classify workers in two types, the passengers and the pilots. So I think in the medical world is still the same. I think there will always be a balanced situation between both because medicine is not an exact science. Like, I mean, I come from engineering. When I start working in medical applications, I realized that this coffee for all and the replicability of outcomes is not. I mean, we can define a treatment, but in some cases it will not work for 100% of the patients. So basically, it has to be a shared responsibility. It has to be AI augmented medicine. And even the World Health Organization has recommended not to replace the doctors, but to really complement in tasks where AI can really bring more value, like predictive analysis, automation of low added activities. But I would say that for me, the doctor has to be the pilot of this revolution in medicine.
Great. Thank you, Anna. All right, Albert, so from the future of Westworld to real-world applications, you're developing AI pipelines to transition how we understand disease into treatment responses. How are you bridging the omics space with imaging? And can you tell us a little bit about how that sci-fi vision compares to the reality today?
So, if we talk about imaging, there has been a big evolution during the last 15 years, and the same has happened to omics. Now we are in a connection point where we can combine the two technologies in what we call spatial transcriptomics or spatial omics, and this is adding a new wave, a new layer of complexity to the typical gene expression analysis, the omics analysis. The main difference is that until now, we were able to understand which biomarkers or which genes were expressed in a specific tissue, in a specific blood sample. But thanks to combining these two areas, we're now able to add context, to understand where this expression is happening, where in the tissue, get the context of the tissue and understand the microenvironment to see where a specific gene is acting, for instance. And this is becoming super important in precision medicine because it's very tied to the immune reaction. And this has a key role both in oncology and immunotherapies. For instance, using this, we can understand, we can predict or we can estimate the potential success of a treatment by estimating how close are the T cells to a tumor, for instance, or understand or stratify patients based on what's the immune cell infiltration they have. In order to achieve that, we need to combine different types of tech. So typically for imaging, we have been using convolutional neural networks to understand where are the lesions, how they are impacting what are the landmarks of a sample. And for omics, it's been more on understanding how different cohorts of patients are having different expression levels. as we can bridge these two things, we can be very precise on how we compare groups of patients, how the treatment, how a patient is responding to a treatment, and from that we can enable new knowledge that we hope and we expect that will shape how we are developing the drugs of the future.
Great, thanks, Albert. Can you just give me one example, or maybe the biggest challenge you face in integrating these different data types?
So actually, I would be happy to say that there is one big challenge, but in reality there are several. One of them is the lack of enough quality labeled data that can allow us to build reliable models. And this ends up in situations where we have a lot of models, not just in Sanofi, but in the whole scientific field, that they work well in the labs, but they don't translate well to the general public. And the key to get to a situation where we can succeed is to have enough data, well labeled, with data that you can trust, so we can train these models. One of the challenges here is data labeling, for instance. If we are trying to understand how cells interact in a specific organ of our body, we need to be able to understand which cells are there. And this is something that the human eye can do just up to a certain level, because when we talk about specific cell types, morphologically speaking, based on their shape, you can identify some subtypes, but you cannot get granular enough. Getting this labeling, getting these levels of annotation, it's the biggest challenge, I would say, that we have. And for that, we are trying to leverage both the human knowledge and existing imaging models, but we're not getting there. To name an example, if you take a coin of 2 cents, you take a tissue sample of the size of a coin of 2 cells, you have 500,000 cells in that space. You cannot ask a pathologist to annotate all this data, because he may annotate well the first 100. If he's really dedicated, he may annotate 1,000. But after that, you have still 500,000 of cells that are going to be shitty annotated. So bridging this, solving this, it's probably the thing that keeps me awake at night right now.
Cool, cool. Thank you, Albert. I appreciate it. Christophe, so when you're facing a tiger, split-second decisions can be life or death. So how is AI helping make these crucial treatment matches with where traditional guidelines kind of fall short?
Yeah, for the tiger, I was 9, so I don't remember everything, and I survived. Actually, today we have, I can say we can face today 2 revolutions at the same time. Albert was telling about how we know much more better now the mechanism. We can get data, imaging data, EMRs, pathology data, which is quite a revolution by itself, because now we have information that we didn't have before. And also, let me focus a little bit on oncology. Oncology is a big revolution since the last 10 years. 10 years ago, you had very few medicine to be able to tackle the cancer, and it was very general medicine. Since now 10 years, we have antibody-drug conjugates, which are cytotoxic targeted, just like chemo, but which target the only cell which has the antigen of the cancer. You have radioligands, which replace the radiotherapy by using also antigen to target the right cell and not the whole body. You have immuno-oncology, immuno-engager. You have DNA damage repair. You have many drugs around epidemiology, epigenetic, problems. So all of this is quite new and a big revolution. And now when we are talking about cancer, oncology in AstraZeneca, we say that our new mantra is eliminate cancer as a cause of death. Because we think that now, with everything we have, it will be possible to live with cancer. Sometimes cure the cancer, but sometimes live with it and be able to tackle the only mechanism which is not working. Especially also with the cell therapy, which is also coming. So we have a bunch of usages and drugs that we can combine together. Not only AstraZeneca drug, but drug from every drug providers. Which means that today, the only way we need to do that, we can do that, the only possibility is not to use guideline anymore. Today, you have typically just guidelines. You go to FDA, you go to EMA, you say, okay, my drug has to work in this condition, and you give characteristics of the patient. And then you give the drug or don't give the drug. Now you have, with all these possibilities, it's not possible anymore for human to know everything what he has to take into account, like 5,000 parameters to define the right treatment for the patient. And the only way to deliver the right drug to the right patient at the right time is to use AI. And the data that we have now and the computer that we have now, which we didn't have 10 years before. So I think now is a very good conjunction of all of this together. We start to make it happen. We also need to change, because it's not only science, we need also to integrate inside hospitals, inside oncology, with oncologists, to be able to have the healthcare professional having access to the data, the same place, and having mechanism companies, software medical companies, able to use this data and to provide them this information. I think it's just like in the plane industry, 50 years ago, when you had like 4 or 5 people driving a plane, and now you have only 2 pilots just because you need 2 for any security reason, but actually the people are doing 99% of the time nothing because computer is helping them to do everything. Yes. So I think we are the same thing like in the plane industry 50 years before, thanks to all of our knowledge and the data what we have available now and AI.
Thank you. I like all the analogies to, or metaphors to medicine, to flying, you know? Please let it work. Yes, yeah.
It's safe now.
So really interested on the multimodal, you know, it is hard, you know, with these multimodal biomarkers and coming to a diagnosis. Is there one particular thing that crosses your mind as a prime example of where AI, you know, was able to solve something that traditional medicine was not?
Yeah, I think Albert mentioned a lot of it. I will just give some examples. Recently, we have done a study with MSK in New York, trying to see how images, not pathology images, just easy images, CT scan. Everyone is doing a CT scan who has cancer. And we were trying to see if we can get some features, radiomics features from the images, trying to help us to predict or a risk or how the cancer is spreading and what could be the good treatment. And we have found very, very good outcomes. We are very surprised to get these outcomes, which was like about 20 different features, not only images, but images, EMR, genetics information. And when we went through the board, the scientific board, the best oncologist in the world said, "Oh my God, you entered in my brain. It's the way I think, the density of the tumor, the shape, all of this, you have modelized it. Now you tell me this, it's exactly how I work, but me, I've got 25 years of experience." So if you want to be able to spread this type of solution inside hospitals when people have less experience, less time, a lot of fatigue also, because oncologists have, like, if you have 20 patients to decide in the same time frame, like 2 hours to decide, you become tired, so you can make mistakes. And then when you see that the machine is as good as physician, I think here it was like a great experience and very interesting to start to roll out the solution within other hospitals. So now we start to deploy it with some partners. And I think it was a very good example, like very concrete. And we had done a lot of publication around that. And this is only the start. As Albert mentioned, a lot of are coming. For example, in pathology, we also try to analyze thousands or hundreds of thousands of cells for TROP2 expression, for example, which is like a mutation. And for example, a pathologist cannot handle it with the eyes anymore. It has to be done via a computer. So this is very concrete things where we are working today. And where we combine all of it, we are able to do precision medicine, because the treatment now we only target maybe 10,000, 50,000 people with the combination treatment worldwide. Right. So this is the only way to do that.
Thank you, Christophe. So I want to leave time at the end for a few questions. So we're going to go right to our quick fire round. And I'm going to ask each of the panelists in 30 seconds or less to give me their opinion on some thoughts around big picture ideas in AI. So the first one is the equality of what we're delivering from a healthcare perspective. Are we going to develop a two-tier healthcare system? So are we creating have and have-nots in medicine? And I'll start with Anna from an IVF perspective.
So I think the divide already exists. before even training the algorithms, right? So we, in ADHD, well, in IVF we see it, so the case of the US is very clear. We even speak about fertility deserts, right? So, and I like your point about the skill sets of the doctor somehow, because we are facing that we always have to live with two business models, the big hospital and more the satellite clinic, where probably AI will really create a lot of value with lower skill sets. But well, going back to the point, I think we are already experiencing this divide. In ADHD, we know that there are some races that they have worse outcomes, less treatment, and in the end, for me, it's all about access, right? If we use these tools and all this combined power to really make something more accessible, I think it's going to be a good outcome. Nevertheless, in our case, we have to include minorities in the algorithm training, because this is what the FDA requires and what we want to do. We want to have a balanced data set, including girls and boys, because in the case of the ADHD, girls are subdiagnosed, and because they belong more to the inattentive type instead of the hyperactive. So I think they are very relevant aspects to consider when you train your algorithm and when you define your data set. And I think, but if the end goal go in this direction, I think we are good. We are even better than today.
I completely agree with Anna on her mention that the divide was already there. It's been there for centuries. It's not a new thing. And if we focus more on how AI is influencing that, I would say that AI is fueled by two things. One, it's data. The other one, it's compute power. Compute power, luckily, it's becoming cheaper and cheaper as we speak. But data still has all these biases. So whilst we have the biases in the data, we are still going to see this separation. Fortunately, as I was saying, the AI is based on compute. Compute is getting cheaper, so it should be feasible to spread out the use of models, the use of machine learning to different stages, different hospitals, different units. But the other barrier here, it's not on the AI models per se, but on clinical tests, lab tests. All of this divide is already there, and it's not coming due to machine learning models. So we don't need to tackle it on the AI side. We need to tackle it as a whole thing.
Great. Thank you. Christophe?
I see it the opposite. I see it as a chance to bridge the two worlds. I would take two countries where I work with, China and Africa, not countries, continents, like almost.
Yeah.
And today the issue they have is not to get the CT scan, is not to get the treatment access, is to get access to a physician.
All right.
It's not easy to send an experienced physician somewhere, but what you can send for very cheap price is data. If you can get the pathology images scanned, then you can send it everywhere. You can send it to a machine everywhere and get the information back.
Right.
You can have your oncologist far from you, because if you get all the data from you, I think it's a chance that you can have a better treatment than having an average untrained physician for a very specific cancer. For example, you need someone who is seeing 1,000 patients a year, not one having one patient or two patients like you a year.
Yes.
So I see there is as a big chance, trying to imitate the way of big hospitals are working on small hospitals. And where I see it brings less value and less time is big hospitals. Because take MSK, take the big center, take Val d'Hebron, the AI things, they will not bring new, no better quality, because the algorithm will be as good as the physician today. Maybe we will save time, maybe we will have a second advice, but it will be the same quality. For hospitals, we have not the same people. It will be huge difference, especially in the countries where you have a very poor access to data. Probably it will be, for me, a chance, really a chance. And Albert is mentioning the power, computer power now is cheaper and cheaper. Probably tomorrow the scan, the pathology scan, will be also very, very less expensive. So I think I see it very as a chance. The only thing I agree with you also is the bias in data that we have today. We have to make sure that the models that we have will also reflect the population which are not treated well today. This is probably the challenge where we need to put a lot of effort to make sure that the models applies to everyone.
Right, right. Thank you, Christophe.